Good evening. I'm Sherry Gleed, Dean of NYU Wagner, and on behalf of NYU Wagner, it is my distinct pleasure to welcome all of you to our 27th Annual Kovner-Behrman Health Forum. This is one of our signature events. It holds an important place in Wagner's history, and today is an especially important night because this is our last forum to be held in the Puck Building. Next year, you'll come to the forum in our brand new, exciting space. NYU Wagner has a long history in public service, both here in New York City and around the globe. For more than 80 years, we've helped our students translate their passions into action so they can make an effective and lasting impact on the public good. Our faculty regularly conducts research that changes the way people understand and act on the most important issues of our time. Our 12,000 plus alumni worldwide are applying their education in a real world context in many fields, many of them in healthcare and hospitals and nursing homes, insurers, and so on, and are making an impact every day. And to make an impact, it's really important that we hear from many different perspectives, such as the ones we'll hear tonight. The Kovner-Behrman Health Forum presents an opportunity for the Wagner community, as well as other thought leaders and practitioners, to hear unique takes on relevant, important, and timely issues in healthcare. This event is only made possible by the continued leadership and dedication of Professor Emeritus Tony Kovner. We're so delighted you're with us. Tony created this forum 27 years ago in honor of his mother, Natalie Lieberman, who made the series possible with a very generous financial gift in honor of her son and of her parents, Dr. Percy Berman and Mrs. Ava Berman. Many of you here in attendance tonight have also given contributions that have helped us sustain this effort and related initiatives over the years, and we are very grateful. Tonight's event focuses on a very timely and critical topic, the role of health systems in addressing the social determinants of health. It's a really interesting topic because it addresses the deep connections between healthcare and the broader societal factors that influence well-being. Tonight, you'll hear from Professor Tom Diano, who's a professor of management here at Wagner, from from Eboné Carrington, a Wagner HPAM graduate, who is former CEO of Harlem Hospital, and who is now at Manatt Health, which is our partner in our newest program, and from Dr. Gbenga Ogedegbe, who is a physician at NYU Langone Health and a former student of mine, so I'm very proud of him. And our moderator is Lauren Taylor, who is an assistant professor at the NYU Grossman School of Medicine in the Department of Population Health. So with that, let me turn it over to Lauren.
Thank you, Dean. Welcome, everybody. I'm really looking forward to this conversation. This has been a topic that's near and dear to my heart for at least 10 years. And so, the title is thinking about the role of health systems in social service delivery. And I think I just want to frame that as the conversation is really about what is the appropriate role for healthcare and social service delivery. And that is a loaded question because it's a normative question. We could have a big role, we could have no role. And I think there's some potentially productive disagreement on the panel, which is really helpful because unless we surface it, it's hard to kind of get to greater clarity. So the way I thought we would do this is pretty organic. I thought maybe I would give 3 minutes of preamble based on some of the work that I did to set the stage. And then I thought we would go Tom, Eboné, Gbenga to sort of layer on some additional nuance and do some call and response, if you will. And I just invite you guys to jump in. There's no need to raise your hand. I'm giving you license to interrupt one another and interrupt me. We will then maybe play around with a couple case studies, like, okay, so how would we feel about the following scenario, and let you guys upvote or downvote, and we can talk from there. And we'll end with some policy discussion before 50 minutes is when we're gonna try and cut ourselves off and then invite some audience questions. Sound okay? Okay, then let me just say maybe 3 minutes of preamble here. So as I said, I've been at this for more than 10 years, which seems hard to believe. But in 2013, I co-authored a book, The American Healthcare Paradox. And I think it was sort of on the upswing of attention to social determinants of health and the role of healthcare systems in addressing social determinants of health. And the argument that my co-author, Betsy Bradley, and I were making was really that, look, when we look nationally, we see the US really pales in comparison to a lot of Western countries in key health outcomes. And yet we spend a lot more healthcare dollars. Part of the reason why that is maybe because we have underattended to what we said was social service spending, but that was sort of a proxy for attention paid to social determinants of health, with social determinants of health being defined really broadly as sort of the conditions in which we live, work, play, and pray. Super broad definition. So think of everything non-medical. The reason that you might think that has some impact on health is because best available evidence tells us that the quality and timeliness of the healthcare that you receive really drives about 10% of your health outcomes, although there is debate in the literature of whether that should be 10 or 15 or 20, but it's rarely more than 20. And the remainder of what really creates health outcomes tends to be non-medical things. Could be your genes, could be your housing, could be any number of other things. So that's why our thinking was maybe it's time to look for leverage points beyond medical care. The challenge is like, okay, if we recognize that, well, then we're faced with a question of how we improve those non-medical determinants of health. One strategy would be you just directly invest in social service spending. You increase spending for food stamps, or you increase spending for affordable housing. And if you think that that's a difficult thing to do politically, you might then say, well, perhaps we want to create policies to incentivize healthcare organizations, hospitals, health systems, primary care offices to sort of get in the game around social determinants of health. And I think Betsy and I in 2013 landed there, saying additional policy that tries to incentivize healthcare organizations to get in the game and recognize and potentially even address social determinants of health was a good idea. I will say I myself have moderated some of those views in the past 11 years, and I'm happy to interject and share some of those with you all. But I just wanted to set that stage, not because I think we were the first to articulate it or the best to articulate it, but because I think that represents sort of a large literature and in some ways like advocacy effort that has been underway now for many years. And I think I want to turn it over to you now, Tom, because I think you and Dean have articulated a key kind of critique of that view. And I think it's a totally valid critique. So I wanted to bring that in and then let Eboné respond to that critique, and then Gbenga maybe round us out.
Great.
Tom.
Thanks, Lauren. I want to start off first by thanking everyone for being here and for everyone who made this event possible. And I want to give again a special shout out to Tony, who was just a fantastic and wonderful colleague for me for many years here. And I miss him. And when I see him tonight, it's really nice to reconnect. So I think Lauren set the stage very well. There's been a real, I think, increased effort for healthcare systems and to jump into providing social services, especially since COVID, when it really became clear that how important the social determinants of health really are compared to other factors. And Sherry and I jumped in. I'm going to give Sherry some credit and possibly deflect some blame on her too. She invited me several months ago to write an essay with her that said, well, wait a minute, what is the appropriate role of health service systems in addressing social determinants of health? I think that we agree strongly that something needs to be done about social determinants of health. The question is, as Lauren put it, what's the appropriate role for which actors and how should they play those roles? And just to elaborate a little bit on Lauren's options there, I think myself that there's maybe 4 types of options here. As Lauren said, the first one is, can we find ways to strengthen social welfare policy broadly defined at the federal, local, and even municipal levels? Secondly, there's a question of, can we find ways to deliver better and more effectively and more robustly social services at the local level? And of course, that's what we try to do here at Wagner, at least in part, by producing top-notch leaders of those not-for-profit and public service organizations. And of course, we have Eboné as a prime example of that. Even though she's been mainly on the healthcare side, we have other Star Wagner alumni who work on the social service side. Third option is are there productive ways, and again, Lauren called this out, but just to emphasize again, are there productive ways that healthcare systems can partner with social service agencies, organizations? After all, they are the experts in addressing social determinants of health. Are there ways for healthcare systems to partner with them? And at least one astute observer of this, Stuart Butler from the Brookings Foundation, said, look, you can partner, but make sure that the healthcare organizations take a backseat and let the people who are experts take over. And then lastly, as Lauren mentioned, there's the option that health systems, large and small, can take on the role of providing direct services, social service of various types. Maybe they can provide a food pantry, for example. So those are the options. And I think, and I agree strongly, that I think our purpose is best served tonight if we look at the pros and cons and the conditions under which those various options will play out. Knowing what we do about the United States, we might end up with a bricolage type of approach, right? Where there's a little bit of this and a little bit of that. And I think our discussion can help illuminate the way forward and what types of arrangements might work. Where I want to pivot and just make a few points here in my comments before I turn it over is to say, okay, let's look at the evidence. What is the evidence base for these various options? And there, I think that the evidence is kind of sobering. My starting point for looking at the evidence is a key article, and one of the most impressive articles I've actually read in a long time was a 2020 or 2022 Milbank Quarterly article by Corton and colleagues that did a rigorous review of all of the experiments that have been done in the United States over the last 60 years to try to improve what we call the social determinants of health to see what is their actual effectiveness. The results are sobering because what they conclude is that there's actually a dearth of evidence. Secondly, they point out that where there is good evidence, it's for investing in early childhood education, income support, and health insurance. Those are the three that garner the most actual rigorous empirical support, but those are not actually the top three that we usually think about in this discussion. Two more pieces of evidence I'd like to call out, and Tony was a big champion of evidence-based management. I'm going to follow up on that by pointing out that there is a long and deep literature of research on whether or not organizations should try to diversify away from their main mission and try to do something a little bit different, even though it seems related. And we often call that diversification strategies. We call that, but in reality, a lot of times it really represents what Sherry and I have called mission drift, and that's what the literature calls it too. And it's probably not surprising to know that once experts get out of their own field, the results aren't that good. And research shows time and again in different settings that when organizations diversify and go away from their core mission, bad things happen. The other literature I want to point out is a literature that I also have been active in for the last 40 years in my own research, which is a literature on strategic alliances. Those are the kind of collaborative local partnerships that advocates for are putting forward, advocates for how healthcare systems can partner with social service agencies. And it turns out, not surprising, and I'm sure there's a lot of experience in the room, what does research show about these partnerships? They most often fail to achieve their objectives. It's lucky for an alliance or a partnership, a strategic partnership of the type that we're envisioning. It's lucky if it can last more than a few years. So after those points, you might say, wow, this guy is Dr. Doom and Gloom. And that's why I want to hand it over immediately to my colleagues to see, because I believe that they're probably going to bring up some good examples that are counterpoints and that can help illustrate the way forward that from their own experience and from their own work, which I think has been quite robust in this area. So I turn it over to you.
Thanks, Tom. And Professor Kovner, thank you for your teaching. I was in your class around management science, and I remember every bit of it. It was a defining portion of my time at Wagner, and so I just want to say thank you. And I will tell you that, Tom, I don't disagree. I think that the level of partnership between health systems, community-based organizations, and the roles and responsibilities should be more equitable, but they can't in reality. And so the primary mission of a safety net hospital is to stay open, and of a rural organization is to stay open. Before the provision of care, it is to exist. And in order to exist, it has to generate some degree of revenue and resist or avoid penalty. And CMS and Joint Commission don't allow excessive readmissions. They don't allow for overt utilization within the ambulatory setting. and they don't allow for you to discharge unsafely. And so the ability for a hospital to not excuse itself, but to hand off to a partner is not possible. So they have to enter this very, very delicate dance with community-based organizations, and really are forced to interconnect the clinical aspects of care with the social determinants. And so most safety net enrolled providers experience patients that have low levels of health literacy, that have to make very difficult decisions as it relates to their very meager income, decisions around buying food or paying even small co-payments for medicine, adhering to appointments when they are not paid for their time off. And so the world of an individual, most often a Medicaid recipient or someone who was uninsured, is filled with choices that many of us don't necessarily empathize with and can't understand. And that is why when they are in front of a doctor, whether it's in a hospital outpatient setting or within the acute care setting, the trusting relationship that's built between a provider and a person is really going to change behaviors more than any engagement with a community-based organization. And that is why I think safety net providers have leaned into it's not a fight, but into the conversation around social determinants. They've started talking about referral programs like Unite Us, Bertha, where they can actually refer patients to the kind of services and supports that are necessary. And then I will say are trying to avoid penalty through very lengthy statement of deficiencies when CMS comes to regulate their organization and says, how safely and comprehensively have you cared for an individual when you discharge them into a shelter and they're coming right back, when you know that they are not able to comply with their treatment or medication regimen, and where you continue to prescribe when you know that they are without the means and the resources and even the understanding to be participatory in their care. And so although we will talk, and I'm very excited to hear Gbenga's comments from an academic medical perspective, in the safety net environment, social determinants are a component of care that's inextricably linked with the ability to provide effective, safe encounters with patients. And then we get into cultural competency, language, and the ability for patients to understand what they're being told and how well they can comply with a random external referral is going to be difficult. And then when we look at one social determinant in particular, transportation insecurity, you are now saying to someone who barely can get to the hospital for their appointments and often overutilizes an emergency department to go to yet another location and navigate another system and provide more documents. And so the ability to partner is important, but also to say, I have to do some of the things while I have this patient in front of me, while as a trusted messenger of information, I can say to a patient, go to the food pantry or go fill out your recertification paperwork, or even talk to me about your interpersonal safety or the toxic stress that you experience. And all of those things many times have to happen within the hospital setting. And if they're not, and if they do not occur, then there is perception, especially by providers, of negligence or incomplete care. And then you're dealing with a workforce that feels, and mostly they're there for mission, that feels that they're no longer complying with that mission. So I'll pause there because I could literally talk about this for hours and hours. But I will tell you that safety net hospitals, rural providers, and those that care for the individuals that struggle and grapple with the social determinants, or who live in neighborhoods where they're building exhaustive transportation hubs, and so they're disproportionately ridden with asthma. They don't really have a lot of options, and they can't navigate partnerships, so they have to go to a one-stop shop, and many times it is the healthcare delivery system writ large that provides them with that. So
thank you very much, Professor Kovner, for having me. Dean Glade for having me as well. It's great to see my colleagues here. So I'm going to speak from the perspective of a physician who is an internist, who's trained in a safety net practice, if you may, at Montefiore in the social medicine program, and who also now leads a large academic medical institution to really solve this problem. So I direct the Institute for Health Equity at NYU Langone Health. So we're on 3 campuses, Long Island, Brooklyn, Manhattan, and we have diverse health insurance programs as well. So if you just take a step back, I'm going to try and frame my own argument differently. So Lauren talked about the idea that a lot of the action for healthcare outcomes is not really within the health system. So if you come to me, I will give you the very best care I can give you, right? But then you're going to go back to where you come from, right? And to your community, to your neighborhood, to your families. And so a lot of those actions is what actually drives. We saw that with COVID, right? It's not what you have within the health system. We actually will argue that disparities in care is not within the hospital, it's between hospitals. What we don't do enough work around is between hospitals, what are those zip codes? And so I want to just level set on certain facts. Your zip code is a better predictor of your health outcomes than your genetic code. So we know your genes explain some variance, but it's not a lot of variance. But where you live does matter. So if you grew up in a neighborhood where you have a heart attack, you call 911, they show up 20 minutes later, then you're worse off than somebody who lives in a zip code that you call 911 show up in 4 minutes, right? So your genes at that point is not the issue, it's the environment, right? So that we agree. The second issue, though, is what Tom talked about around the idea that there are different nuances on how we look at this. Do we have structural interventions? If we have them, do they really work? And it's true, the evidence behind them is not solid. I would argue that when you look at the structural or social interventions, or call them, the duration of those interventions is not long enough for us to see the outcomes we're looking for. And I would argue also that if you really think about it, it's like saying that what is the return on investment for preventive medicine? This is why the CDC suffers a lot. The ROI is very small. If you give somebody a vaccine today, and we're looking at how many lives you save 4 years from now, it won't be a lot. 50 years from now, you transform medicine. So that's important to appreciate. The other point I would make is that, Tom laid it out really nicely, that, is it that as a government, as a community, as a country, are we investing in those so-called social determinants or those structures? Or is it that, we have really strong social programs that can actually be innovative in caring for people? Or is it that we have a really strong healthcare system that can do its job for what is trained, or is it a partnership? I think it's a partnership, and here's why I believe it's a partnership. When you look at the way we reimburse healthcare today, right, we have major metrics that we look at in our health system. Length of stay. If you go beyond a particular length of stay, the healthcare system has to pay for that. Observed to expected mortality. If it is not good enough, your contract with the health insurance companies becomes a problem. We use something called readmission rates. You come in with heart failure, and we take care of you. If we discharge you and you're back within 10 days, we're going to eat that money up. It's not your problem, right? So I think healthcare institutions are becoming more and more savvy in how they think about this. So at Langone, what we're doing is saying we need to think about a community clinical linkage model. The idea being that, if we screen you for the health-related social needs, I have to stop here and really make a distinction here. Housing, transportation, making sure that people are educated, and making sure that you actually have a job. Those are not things that a health system, actually, frankly, I'm not trained to provide people jobs, okay? I'm trained to take care of them, given the complaints they have in front of me, or whatever their risk factor is for a particular disease. But the health system can actually screen people for what we call the health-related social needs. The things that we know that are mutable, they're changeable. You have organizations that actually address those. So transportation instability, housing instability, food insecurity, the evidence that those things are linked to outcomes is actually very robust. Post-COVID, we see more and more of that kind of evidence published in major medical journals. It didn't used to be the case when I was in training. In fact, as a physician scientist, my work is focused on narrowing the racial gap in the burden of hypertension between Black and white, and looking at how we implement evidence in practice-based settings that actually can narrow that gap. And when I began my career, I was told I'm going to fail. That's not something that we study as a healthcare system. It's not something we look at except if you're in a safety net practice. So today, though, we talk about it a lot. So at the institution, what we're doing is saying that if we can screen people for those health-related social needs, the kind of food you eat, intimate partner violence, food insecurity, transportation problem. Just think about someone else had a fascinating treatment for cancer, okay? And then we send them back to get rehab somewhere. But where they're going to get that rehab, the nearest place to them is 20 miles or 15 miles. How do you resolve that? They're back to you with recurrence because they didn't have that rehab or whatever it is. So we've got to, if we can screen for those things, then we've got to forge a partnership with the community-based organizations who do that work. And then say, if we have this partnership, we're not only referring you to them, so Find Help, Unite Us, they're referral platforms. The problem I have with them is when you refer people out, I need to know what happened to that person. Can we track the outcomes back to the system? In which case, then we're truly now talking. I think that's where the needle is going to start moving. The Joint Commission just mandated that every health system must have a systematic way in which we're screening for health-related social needs. I mean, I feel like I'm in paradise right now. Everybody's speaking my language. But here's the problem. Here's the rub, because I think it's very important. I think the moment you incentivize that, you've got to ask the question, are we training physicians the way they should be trained to appreciate these needs? And the answer is no. I think even within safety net hospitals or practices, they just practice it. I don't know that we have a formal training the way we should. So at the medical center, what we are doing is that we're going to infuse the whole aspect of health equity into how we train our providers, how we train our students, residents, and fellows. That will take time. You've got to build that infrastructure. The second thing I think is important to appreciate is that when you refer people to these CBOs that we're talking about, they don't have, honestly, the bandwidth to actually begin to do this. So what we're trying to figure out then is, okay, what do we know about the intersection between all these social needs? We can collect data. Data science is huge. Can we create a model that allows me to tell my CEO that, hey, listen, Bob, if we invest in people who have disability, low SES, they have food insecurity, the biggest bank on our buck is this. Maybe then we'll build the infrastructure to address that. But that will change at any given time. So we need to have a robust database that allows us to begin to look at that evidence. And then finally, I think, who's going to pay for this? I think that's a big problem now. Now we have Z codes, that's what they call them. If we screen for people for social needs, we can capture those codes. We're pushing our system to capture at least 85% of that code at the end of this year. But what does that mean? You have to create a new workforce, community health workers, who can be in between. So what kind of quality will they provide? What's going to happen to the quality of care? These are the kinds of questions I think we've got to grapple with. But I think ultimately, we really are going to move in that direction. That is the nuance I think we need to begin to think about. And then let me end by saying that, you know, evidence-based medicine is great. I grew up in that era. But here's the problem. Evidence-based medicine is as good as the resources you have in that health system to address it. If you go to a neighborhood practice where we're saying, give people 3 blood pressure medications if their BP is a particular level, I'm making that up. When you go to those neighborhood practices, they don't have the resources to practice evidence-based medicine. So we began to say things like practice-based evidence. I think Larry Green has been talking about this. In other words, can we evolve our evidence based on the experience we have within the practice? I think for this particular problem, we're going to have to learn as we're moving along in this.
Thank you, guys. I have a couple quick follow-ups to come back to you on. And one is just that, Eboné, I heard you saying, well, let me back up. I heard both Tom and Gbenga saying, yeah, partnerships. Partnerships is where it's at. And I heard you kind of saying something maybe slightly different, which is, I don't always have the luxury of referring someone out to some community-based partner because that's another bus ride away, or we don't then have the turnaround in terms of clinical information exchange. So like, we gotta kind of do some stuff here. And I just wondered if you would speak a little bit more to this nuance about under what conditions does a partnership make sense? Because of course it sounds like first pass, oh yeah, then we get to have our cake and eat it too. We can satisfy Tom's concern about mission creep, and we can feel good about meeting the moral urgency that people don't have what they need. But I heard you saying not always possible, so I just wanted to give you a chance to respond.
Sure. I would say I have now agreed with Tom in that partnerships are important and likely preferable. Why they are not always easy to effectuate is because the level of competency and the capabilities within community-based organizations, to Gbenga's point, is limited. They have amazing mission, they have amazing reach, and they have amazing community credibility. However, the technical assistance necessary and the infrastructure in terms of information systems, onboarding, hiring, just the ability for these CBOs to continue to exist is compromised. And so legislative and policy support as well as funds flow is necessary before we can talk about effective partnerships, or you're referring someone to a very appropriately missioned but mediocrely run organization. And that is not helpful for people that are compromised. So hospitals that by virtue and then of their mission and their way of being regulated, they have an EMR, they have social workers, they have the ability to do onboarding, training, develop. They have more capabilities. And so if they're partnering, they're then just a dominant partner. And as the dominant partner, the question is, how are we shifting that focus from clinical medicine to and eliminating the social care burden and responsibilities to community-based organizations without some level of distribution of funding and operating capital. And in safety net organizations that are often, if not always, in deficit by virtue of a lack of rate parity. So in New York in particular, Medicaid reimbursement is 62 cents on the dollar. And in commercially organized and insured institutions, it's $3. And so we're looking, at Manatt in particular, to advocate to at least get to average commercial rate, but it's right now 62 cents on the dollar. So they then having to infuse cash into a partnership is not a realistic solution. And that's the only pushback. I think if we were to build a model and theoretically talk about who should have what responsibility within a patient's care, we could easily say hospitals do this and CBOs do that. But when the person is here and they have to be discharged and they have no medication or they have no safe housing or they're going back to an intimate partner violence, you're going to get penalized. And through the Joint Commission tracer methodology, you will actually look negligent if you send that person back out and say, but I gave them a referral. I handed them something this thick in terms of an after action or discharge summary and said, do all of these things, and forget that we didn't even question whether or not they know how to read or understand or comprehend what we've shared with them. So I am in total agreement with the theoretical partnership conversation, but think we need to move from the policy and funding and legislative perspective really to advance the ways in which partnerships can be effectuated.
Yeah, I think you raise a very important point for me, Lauren. I think, so we're trying to evolve at NYU Langone Health. We say, look, we have to build that infrastructure. Even if you refer that person to the CBO, I'd like to know what exactly did they do? So I think the latest iteration of, I think it's called Find Help. That's what one is in our health system. It allows us to have, so EPIC is the system we use to have some kind of integration that's embedded within the CBO so that if they're there, we can get that data back. The problem is this, is what you said. Who is going to do this? Who is going to be responsible for that infrastructure? Social workers are overwhelmed, it turns out. I'm learning this now myself because now we have to create the workflows within our health system. We have to do a massive work trying to understand what is that workflow? Who's going to screen that patient for those social needs? And once you've screened them, what does that mean? If there's no imminent safety danger or something, who's going to take care of that? So we're proposing that we need to have a community health worker workforce that's very well trained and that's embedded within the health system because then they can understand quality. but they have a solid relationship with the CBOs. Now, that's why we're piloting that at NYU Brooklyn as part of the Beyond Bridges initiative. But I think that will require us to really step back and ask ourselves, what does it mean? What I like about where we are today is there's still wins. With the Joint Commission mandating folks to do this, we want to be ahead of that curve. Actually, I proposed this 3 years ago before the Joint Commission. I knew I was going to get a pushback because, like you said, who's going to pay for this? The community health worker issue is not something that people talk about enough. What about their training? So in West Side Chicago, Rush Presbyterian, they actually came together and they created a consortium. And we brought them to talk to us. Fascinating consortium. It has a CBO, it has 4 or 5 health systems, and it has really leadership talking about what we do with our community. The problem is that nobody owns it, okay? And so if you don't own it, what does it mean? And what is the quality? How do 5 health systems agree on the quality that the community health worker has to provide? So here, we don't have that problem in our system at least. So we're thinking if we can pilot a similar program, it may help us appreciate what I mean, learning the evidence by practicing it. I think we'll get somewhere. The final thought on that, and I think you raised a very fascinating point, is that who's going to train these people, right? How do we even train them? What does the certification mean? Because if you're a health worker working with transportation issues, you may not have the skills around what do you do when there's intimate partner violence. I mean, so it's a lot of things that we have to walk through, but I think we're on that journey. I don't think we're going to.
I had just a quick double tap of what you've shared. I'd like to credit New York State and the 1115 waiver construct for trying to address some form of this in the workforce investment organizations. So the WEOs, they're called, are funded to be able to create the supplemental workforce and to ensure that they're appropriately trained and certified. The question is, and where we have to go further is, when they then intervene with the patient and begin to chart and document, how can we then get reimbursed for that? Because health systems lean into what generates revenue. And so when we start to place importance on the supplemental workforce that we know have evidence-based interventions that matter and that move the needle on patient behavior, then we will be getting somewhere and the money will be moved appropriately. So I think New York State has started by conceptualizing a funding mechanism for the workforce training, but then without reimbursement, they'll be the first to go when financial hardship occurs. And so that's what often happens. The most impactful, lowest cost employees, because they're often non-unionized, are the first to be cut when there are operational challenges that exist in organization.
Right. So I just want to reinforce how excellent I think the discussion is of both Gbenga and Eboné, because they're raising all of the key tensions and key questions. Where are we going to get the workforce to do this? What about the information technology that we need to follow individuals from one service to another? How about the transportation that they need? What about strengthening the CBOs, which are historically weak and right undermanaged, don't have the capacity? I think that you're raising all of the right questions. I don't see any simple answers here, but at least I see the right questions. And I will say this: there is definitely a tension when we say that health systems somehow are going to find the resources to provide these services directly because referrals don't work, and we know they don't work, right? There's definitely a tension between saying that and that we need to fund the CBOs better, because maybe whatever dollars the health systems, however they were getting those dollars to fund the services directly on site, those dollars could have gone and maybe should have gone to the CBOs. And so I think there is a tension there about the funding streams, in addition and over and above the questions about the workforce, the information technology, and the actual capacity of the CBOs themselves.
I think this is a really key point, and it transitions us to a policy last 8 or 10 minutes here. Tom, the question of whether a dollar invested in a healthcare's delivery organization's effort to collect health-related social needs data or even stand up a social service could alternatively have gone straight into social service is one I would love to hear your thoughts on, because my impression is the politics of this country are we can spend as much money as we want in healthcare. You can just throw things into a healthcare budget and there's some oversight, but it's not the same scrutiny that comes down when you try and say like, I want to expand a social service line in a budget.
The politics are, you put your finger on it. I think we had some discussion of this earlier. The politics are so difficult. We are a nation that has individualism in its DNA in our culture. And the minute that you say social and then put anything after it, social service, social security, social welfare, there are political issues that are raised. And so I think that the politics of diverting the dollars where right to the experts in social service delivery, that's where the real push is. And if I had an answer to that, I would, right, maybe run for election myself. But I think that's right, because the politics make it so hard. Now, what's interesting about the Medicaid waivers is exactly what you're saying, right? I'm not sure how much folks know about this generally, but New York State, among other states, has gotten a waiver from CMS to be able to spend in New York State alone $8 billion to provide social services to address social determinants of health issues. But it's exactly as you say, Lauren, it's because the money is coming from Medicaid and not some sort of social fill in the blank program that we're able to use those dollars. Question, I think, is really a critical one for research and evaluation and wise experimentation, is to see what we can learn about how those $8 billion are going to be spent over the next 3 years, and whether or not our colleagues in state government and Medicaid, the managers there, will be able to effectively move the money to community-based organizations to make a difference in addressing the social determinants of health. That could be possibly a political opening and provide some evidence about where we should go.
Yeah, I want to just come to you guys for the last 5 minutes, but flag that I think this is such a key thing in thinking about health policy and policy generally. Like when we're trying to solve a problem, it deeply matters what we consider possible and not possible. And if we say moving money directly to social services is impossible, then we have ceded sort of the ideal path. And we're now in a highly, highly non-ideal world of trying to patch together things. Maybe we can fund it through the healthcare system, but it's not great because we know that money could be used elsewhere. But I just wanted to flag it for people, especially students, like that choice of what we decide is within the realm of possible or outside the realm of possible. And we're just going to work from there, really has a huge effect on where you land in terms of both like your policy and your managerial prescriptions. We have 5 minutes left. So Eboné, Gbenga, anything you guys want to kind of wrap up the policy point on? Where do you think we should go, or what mistakes do you think we've made so far?
I think we did not touch on one important elephant in the room, is the insurance companies, right? So at the end of the day, they sign the contract with the healthcare system. At the end of the day, they have to have a population health view of the lives they have. So the truth of the matter is, I think, at least that's what we're trying to do with Medicaid managed care. I think it's health first. To really think through, who owns what, if we're thinking about these problems. If we're covering 50,000 of your patients or the lives that you cover within the NYU Langone health system, what exactly are you going to hold us accountable for? What if we partner together to figure out how we're going to address those health-related social needs? And then who's going to get paid for that? I think that group has to be at the table when we talk about this, because that's where the policy, the incentives begin to change in real meaningful way. So that's, and I should mention that some hospitals now, UPenn, they actually pay for housing. I find it interesting. And others actually say, we're going to invest in food insecurity. So NYU Langone Health, we signed a major contract with a food, insecurity food delivery vendor. God's love, we deliver with the thinking that we're going to know which of our patients are food insecure, and we're going to refer them. Now we're struggling there too. Everything is new. I'm thinking, well, we can do that, but let's build a model. Who exactly needs it? Is that what they need the most? Is there something else we can do to improve their health outcomes? Again, this is forcing us to really begin to think about all these different models that I think will emerge in the next 10, 15 years to come.
I would just add the role of public-private partnerships. and the responsibility of very large academic medical centers to support this effort. Less equipped to handle patients with significant social care needs than safety net hospitals are academic medical centers because they have no capability of screening, managing, handling folks that have difficult presentations, both physically and socially. And if safety net hospitals or rural providers close, these patients will start to, quote unquote, from a CEO that I have worked with, darken their doors. And it means that they should have some skin in the game in terms of providing support to these less funded organizations and maybe even the community-based organizations because they have excess margin. And if we're talking about population health and responsibility, I think even folks that have disproportionately high commercially insured patients should have a discussion or should be participatory in this in solutioning. So I would just say that in addition to funding from the states and policy solutions, that those that are generating significantly large margins should have to invest something into the population health capability of more underserved communities.
I'm smiling because what everyone is saying, something called the anchor institution. Like, they have to really invest in the community. It's a huge debate within most academic medical centers now. What's their role in that?
What do you think our bosses would say about excess margin, Gbenga?
I have no comment.
I won't put you on the spot.
I love
It's
that
time to go
term.
to questions. You're all gonna save Gbenga. I don't know how best we want to do this. If there's there's a mic coming around. So maybe we'll go here and then back, and then I'll come over to you. Those three, I bet will fill out our 10 minutes. Oh,
We can probably.
right here in the front. Yeah, this gentleman. Thank you.
My question to you was getting in to a quality hospital, getting out alive from a bad hospital. There are quality hospitals in New York where poor people can't get in. Columbia, Presbyterian, NYU, and the other one. And there are poor hospitals, like Howard Hospital, but people do get in, and they don't come out very well their lives. So my question to you is, how do you ensure quality of service from the medical staff and from the hospital staff who mistreat the customers, the clients, the people who come into the hospital because they're poor? How do you ensure accountability on the part of the hospital to help make sure that poor people get the best of care and get access to the best of the best professionals? I don't see how any of this discussion has related to those really serious problems.
I'd love to just emphatically and respectfully disagree with the quality conversation from the public hospital perspective. I have seen absolutely phenomenal care, research, and quality outcomes in the public hospital system. And because they care for the poor, I think they're in many cases overly scrutinized. But I will say, if you look at measures that matter, board pass rate of the residents, readmission, infection rates, emergency department length without stay, when you look at the measures around quality and you look at health and hospitals in particular, you will see that some of the brightest minds in medicine work there because it is, one, attached to their mission, and two, we all have the same requirements. The Joint Commission and CMS don't discriminate in terms of their quality outcomes, what they see at Harlem versus what they see at Columbia. Now, I would say where there's such a disconnect is around physical plant. Is it on the newest MRI? Is it on the single slice CT? Does it have the newest edifice? No. But I would say that the people of New York are getting very good care in the public hospital system, and there are going to be challenges everywhere. I used to look at every complaint, every sentinel event, every reportable incident. And the question is, would this happen somewhere else? Were there components of implicit bias present in this care delivery frame? And the answer was no. And sometimes the answer was yes. But I would say that if you look at how a heart attack is cared for in one hospital and a heart attack is cared for in another, and you were to look at time to the time to the scanner and the interventions, you would see comparable care. You would see it in a very different environment. But I just have to stand up for safety net hospitals that often have such a bad rap as it relates to quality when it's really the wrapping and the physical structure around them. Now, we can agree to disagree, but I would just have to say that the quality of care that's provided to public hospitals is strong, and I would just stand behind it.
I want to just very quickly agree and support Eboné and say that it is pretty clear that patients who come into safety net and public hospitals are actually sicker than patients that get admitted to other hospitals. And one of the reasons that's fundamental to why we're here tonight is because the social determinants of their health have actually been worse, and they show up there in worse at public hospitals and safety net hospitals in worse condition than their counterparts. The same heart attack is not the same.
Thanks. I think we had one question, if we can keep the mic moving. Or you can yell.
Yell at us.
Hi, my name is Brian. I'm a student at Wagner, and my question has to do with what you, Dr. Ogedegbe, said about training physicians, how the training isn't really centered on health equity. And I'm wondering what's being done in that area, or what you would like to see being done to better incorporate the training, or even to anyone, who would like to speak to that.
Yeah, let me speak to that. So the Institute has 3 mission areas, as most medical centers, is to serve, to teach, and to discover. So the teaching aspect of that is, I'll just take race, for example. The way we talk about race is as if it's biology, right? So if you look at patients who have diabetes, more likely to be Black or Hispanic, hypertension, same thing. You're going to hear things like, well, there's some genetic predisposition around that. And that's how most of us were taught. In fact, I'm a hypertension specialist. For a long time, I will preach that the way the medication we give to certain patients should be tailored to their race and ethnicity. I'm guilty of that, maybe until 10 years ago or 15 years ago, when my mentor, Tom Pickering, said, is the blood pressure stupid? In other words, biology is the same. We've got to teach it differently. So now we begin to teach that it's not your biology that's the problem, it's the conditions in which you live. So in other words, if we can begin to teach people that there are certain things that modify the effect of treatments in people, then that's very important. That's one thing. The second thing is experiential learning, right? So we set up something called the ACES program just the past year. Basically, the idea is that we're a 3-year medical school. Most schools are moving towards that now. We pioneered that. If we can make sure that within a period of 8 weeks, we have those 2nd or 3rd year medical students, mostly actually 2nd year, spend time with us in the institute, whereby we're partnering with CBOs so they can spend time on those buses, on those shuttles, to see what those folks are doing, and to appreciate that there are social needs that you have to address in patient care. It begins to make sense. Now, if you train in Harlem or Bellevue or somewhere else, you're part of that. My training is social medicine. 6 months of the year, I'm out in the South Bronx. I didn't know what the hell I was doing there, but it was part of my residency. Today, I'm glad I did that. Why? Because they taught us a lot of stuff about the home and the lived environment. That's not something that is common in the medical schools. So we're trying to infuse that into how we train. And then finally, we think that, when you go to med school, very aspirational dreams. When students come in, man, they want to change the world. They finish med school, they're beginning to change a little bit. They become residents, they've changed a lot. They become fellows, they've really changed. They become attendees. Say, what happened in those 8 years? What happened? What happened was, in those 8 years, they lived in the hospitals. They don't have a good sense of what's happening in the communities around them. So we want to begin to change that for the residents and for the fellows. And then finally, we're creating something called embedded learning health equity health systems. What that means is that we're going to put a filter, health equity filter, on all our metrics. We've created a dashboard on quality, safety, even root cause analysis. If we can build a health equity data hub, then we can begin to train people around that as well. So those are the kind of things we're beginning to do, at least at the NYU Grossman School of Medicine.
I think we have one more question. Oh, there's a lot more questions, but we're only going to have time to take one more question in the forum, and then we'll all hang around and chat a little bit more. But let's do one more brief, and we'll try and keep our responses brief.
Sorry.
No, that's okay. You were the perfect person to be asked. How do you think we should train people differently to center health equity?
Hi, my name is Titus. I'm a student here. My question was around, we're talking about the distance between hospitals and when people go back to their environments and whatever. Isn't there like a lot of evidence about how para workers and in developing countries, how they've bridged a lot of the gap with like the basic healthcare services and how that might increase access to primary health care, at least before things can get really bad that you need to be at the ER. And that's a different context entirely. I know developing countries and all of that, but is there something we can take from that?
What are the opportunities
I
for
can
reverse
take-
innovation? Yeah.
Well, I can take a quick cut at that from a kind of a narrow, but hopefully helpful way. I recently reviewed literature on community health workers in the developing world, and the evidence base is actually going back to Gbenga's point about the training. The evidence base for well-trained community health workers is quite strong and shows that they can do quite a lot of good work and make a difference in health outcomes. And I think that their role, we need to, again, agree with Gbenga, we need to expand that role here in the US, but because it does work and the research is pretty good around it. For example, community mental health workers helping to support the delivery of mental health services of various types in rural and developing nations. And I'd be glad to follow up with references for you.
So I can give you briefly, my night job is to do global health. So I'm from Nigeria originally. So we have several grants in Nigeria and Ghana where the language we use is called task shifting. So the reason you have non-physician health workers doing most of the work in a place like, let's say, Nigeria or Ghana or Tanzania for that matter, is because at the height of the epidemic for HIV, we're seeing a rise in what they will call non-communicable disease, diabetes, hypertension, obesity, cancer. And all this is happening in the context of three major factors: acute shortage of healthcare workers. WHO standard is 1 to 1,000 physicians. The US is 1 to 440 something. Nigeria is 1 to 5,000. Tanzania is 1 to 50,000. So what that meant is that the system has to quickly adapt to train non-physician health workers to address HIV. And that's what happened. And they staved off the epidemic. And if you can do that for HIV, where at least we're talking 15 years ago, where the medications were very toxic, it can certainly do that for hypertension. We did that in Ghana and they changed their policy, where nurses can treat hypertension if it is uncomplicated, which 70% is, right? And so that's, here we call it reverse innovation. We're beginning to see that now. We're building evidence around that to show that team-based care can address diabetes and hypertension care. Nobody pays for it yet, but we think, that's going to.
This has been sensational. Thank you three. Thank you, Tony, for being the impetus for this all. We'll see you at the reception.